PACOP Morning Tea Talks.
Welcome to, I had to think of the month then, August.
Yeah, August Morning Tea Talks. Gosh, it's only just August, isn't it?
Yeah.
Last day, we just snuck in there.
It'll be
So
Christmas before we know it.
last day of winter today. So that's exciting. Spring is in the air. So good morning, everyone. Today we welcome to PACOP Morning Tea Talks. This morning we are going to be talking about the phase, the palliative care phase. And I'll hand over to Laura.
Thanks, Nat. So before we get started, we'll do our acknowledgement of country. So PACOP comes to you from the University of Wollongong, which is based on Dharawal country. And I am from the Wadi Wadi country in Shellharbour. So we really want to acknowledge the importance and that sacred connection that the Aboriginal and Torres Strait Islander people have with the lands and the waters that we all come from as the traditional custodians of the lands we're meeting from today. And pay our respects to elders past, present, future, and emerging. And we thank them for all of the sharing and the insight that they're sharing in that palliative care space as well. So today we're going to talk about phase, which is part of the outcomes component of PACOP. So we know that the first half of the program is really about supporting earlier identification of palliative and end-of-life care needs. And outcomes is really a model of care for delivering palliative care for our residents. And so part of that assessment is what we call the phase. And the phase helps us know how often we need to go back and reassess our residents and monitor them, and really helps us inform the care planning as well.
So the phase is actually the palliative care phase. And that's good to really concentrate on that, because we're not talking about the phase of illness, we're talking about the palliative care phase in relation to the plan of care for the resident.
Absolutely.
So you'll see on the form, Laura and I, we tag team. So we're just going to jump in and talk over each other. And hopefully by the end of it, you're going to go, yeah, we understand completely about phase. So phase is, something that we include, as Laura said, as part of our outcomes collection. You'll see the outcomes collection form in front of you. We've got all our other assessments first, and then we've got the palliative care phase at the very bottom. You'll see it at the very bottom of the form. And the reason for this is because ideally you would be doing all your other assessment, using all your other assessment tools as you assess a resident, and then based on the results of those assessments will help you allocate the correct phase. So there's 4 phases. We need to talk about the 4 phases. We've also got that on the bottom of the form. First of all, we have stable phase. We'll talk about what they mean in a second. We have unstable phase. We have deteriorating phase, and we have terminal phase.
Absolutely. And I think too, Nat, it's really important for the aged care homes to know, like you said, it's not sequential and they can move back and forward. So you might see residents go from one phase to another.
Yeah, and that really becomes clear as you understand what the phase is for. So once you understand the phase is entirely related to what we need to do for the resident in relation to their plan of care, it makes perfect sense that obviously other than terminal phase, which is allocated when someone is actively dying, the phase can differ from assessment to assessment based exactly on what we need to do for that resident at the time of assessment and allocation of the phase.
Great. Let's have a little look at what the 4 phases are and have a chat about how we might know when one phase is transitioning into another. So let's have a look at stable phase. So stable in the palliative care phase is in terms of our care planning, it's letting us know that the care plan is currently meeting the resident's needs. So they may have complex care needs, lots of interventions and lots of input from the GP or from your palliative care team or your clinical, if you've got a CNS or someone there, but the needs are being met in the existing care plan.
Yeah, so stable doesn't necessarily mean simple. Like Laura's just said, it could mean simple. It's really got nothing to do with whether their care plan is simple, whether their care plan is complex. What it is to do with is at the time of assessment, the care plan is meeting all of the resident needs and you do not need to change anything. So therefore, stable phase is the appropriate phase.
Yeah. And how that might look in your resident is the symptoms and problems from the other assessments would be quite stable and they would be quite mild to absent. So the interventions that we've got into place are working. And when those symptoms or those care needs start to increase, that would be the end of the stable phase. And then we'd really need to allocate a different phase to them. So Nat, do you want to talk through what unstable phase is and how that might look in the residents?
Sure. So once again, the phase is relating to what we need to do for that resident to meet their needs based on current assessment. So unstable phase means that something needs to be done because the care plan needs a change made to it and it needs to be done urgently. So, and a good example of an unstable phase would be you've done the rest of the assessments and you've highlighted that, for instance, the resident has high distress scores in relation to pain, and you as a clinician have also assessed the problem severity score as a 3 for pain. You look at the care plan, there's nothing available that isn't already being utilised, so it would be entirely appropriate to allocate that phase as unstable, because what that is saying is we need to do something for this resident and we need to do it straight away. Another example of an unstable phase allocation would be for the family carer, for instance. I mean, the resident themselves, all their scores might be absent to mild, there might be no issues, but the family carer assessment in the problem severity score might be assessed as severe because they are very, very, very distraught, or whatever the case may be, to cause that severe number 3, problem severity score. So therefore, you would also allocate unstable phase in that instance, because it means that something needs to be done to help that family, to speak to that family, and it needs to be done straight away. If they're distraught enough to get a severe score, we need to act upon it straight away.
Yeah, absolutely. And once we've then done those actions, we've looked at the care plan, we've escalated care to perhaps the GP or your palliative care team, and things have been put into place. When those symptoms or problem severity scores start to change and come back down, that's then when we would look at reallocating a phase to either stable or deteriorating, or if they're, approaching that end of life or they're actively dying, that would be a terminal phase. So that's where the unstable phase would then be indicated to change when those symptom scores come down.
So if you were going to allocate an unstable phase to anybody, you would then go back in the following day and reassess to make sure that the interventions you've put in are working. I mean, and if they're not, they still need further sort of, you still need to be monitoring them closely and reviewing them. You could keep them in unstable phase, but if they're starting to work, like Laura said, then that's the time that you would probably go in and reassess and go, okay, I think we can take them out of unstable phase and put them into whatever the relevant phase is.
Yeah. And deteriorating is really about this gradual worsening of symptoms or a new symptom, but perhaps something that's anticipated. And it means that within the care plan, we've got some provisions or some strategies in there to try and manage those symptoms as we expect them to worsen. So that might be something like having some PRN medications written up, a lot of anticipatory meds, those kind of things. And so as we kind of can then see those interventions being used, we're monitoring how effective they are.
Yeah, so a good example of allocating a deteriorating phase would be you've done your assessment, you look at the care plan, everything is working at the moment, but you can see that the resident is starting to change. They're starting to deteriorate, either with the worsening of current symptoms, or they've got a new symptom, but it is anticipated, but you can see that things are starting to change. So therefore you would allocate deteriorating phase, because that would indicate, okay, we do need to have a look at this resident overall, but it's not urgent because you wouldn't put it unstable. But we do need to have a look because things are starting to change, and we really want to make sure that we have everything accounted for as far as possible in the care plan.
Yeah. And again, that would then change as symptoms either worsen and we don't have considerations in the care plan, or as symptoms then are managed and become kind of absent to mild as well, back to stable. So there is some movement there with deterioration as well. And again, as we talk about terminal phase, we'll have a chat about that. Nat, do you want to have a chat about terminal phase?
Yeah, sure. So, terminal phase is allocated when a resident is actively dying. So, based on your assessments and what you know about the resident, you think this resident is likely to die within days. It would be appropriate to allocate the terminal phase. Now, the terminal phase trumps all other phases. So, what that means, if you were to do your outcomes assessment on a resident and you thought they were terminal, but you also thought there were things you needed to do straight away. So, i.e., you would normally allocate an unstable phase. In this instance, you would allocate terminal phase because terminal phase really is alerting everybody to this resident is our priority. They are actively dying. All eyes on this patient. The nurses are going to start their shift. For any terminal residents, they're going to be making sure that everything is as it should be. The family are aware. The symptoms and problems are adequately being managed. All that terminal care, your end of life care pathway has been started. So that is why terminal phase really trumps all other phases, because as soon as you allocate a terminal phase, that should be our absolute priority to look after that resident. Now, having said that, there are times when you may allocate a terminal phase to a resident because they appear from your assessment and from what you know that they are actively dying. They then may, after a few days, they might start to stabilize and even improve. Now, we all know, this doesn't happen a lot, but it certainly does happen. And if that happens, that's absolutely no problem. You would just reassess them and then put them in the appropriate, take them out of the terminal phase and put them back into one of the other three phases as appropriate. So, and terminal phase is not something to be scared of. If you think the resident is actively dying, it is very, very advisable to put them in the terminal phase, because it's going to mean that you're going to be really looking at this resident closely. And either you'll be, they will go on to then die and they will be having your full attention and that of the team throughout those last days of life, or they stabilize and that's no problem. You put them back to another phase. If, for instance, you were finding that you were having a lot of residents that were allocated terminal and then taken out of the phase and put back another one, maybe that's cause for a little bit of staff education about recognizing active signs of active dying. But I think in the most cases you'll find that people are pretty good with allocating the terminal phase as appropriate, and like I said, we all have those residents that rally and come back, and that's great, and that's absolutely no problem.
And I think there's within the aged care as well, there's a lot of resources and focus on end of life care planning as well, so that you would use that terminal phase in what's the word, in conjunction with your organization's end of life care pathways, all of those things as well, to have that holistic care. And our clinical guides certainly help provide some evidence-based responses and suggestions for your terminal care planning as well. For all of the phases, there's prompts and responses there.
Yeah.
So now we've developed kind of a simple little review of how to kind of check and have a little think about whether we've allocated the right phase when we're doing outcomes and when we're starting with the outcomes assessments. And so we've got three kind of questions that can help that clinical judgment around if you think you've got the phase right for your resident. So we start off with that first question, that all-important terminal phase that trumps everything else. Is your resident expected to die within days? So if that was a yes, then they would be a terminal phase. If it's a no, then we prompt you to consider, the resident's current care plan doesn't meet their addressed needs. If it's a yes, then they're stable. If it's a no, then how quickly do we need to respond? Is urgent action required to update the care plan or meet assessed needs? If it's a yes, then they're unstable. And if it's a no, then it's a deteriorating phase. And we still may have some actions to take with that deteriorating phase. Perhaps we need to liaise back with a GP or with the family or with allied health, but we've got a little bit of time around how quickly we need to put those into place. So those are really the three key questions that can help decide which phase someone was in.
Yeah, that's good.
And
some
so
people love flowcharts and some people don't. So it depends how your brain works. So that's a great tool if you love them.
If you're a flowchart person, absolutely.
Yeah.
And so this is an example. We thought we'd give you a simple example of how this might look once we've completed a couple of these outcomes assessments and how it's documented on the tool. So do you want to talk to some of these, Nat?
Yeah, so this is really on the assessment form that we showed in the beginning. We've just
Mm,
snipped across the bottom as though this is a whole page completed
mm,
of assessments. And this is what it might look as your, you've obviously already identified that the resident is palliative. That is why they're in the outcomes collection. So you would be assessing them. So the palliative care phase, first of all, we've got unstable. So you've assessed that something urgent needs to be done for the resident. When they're in the unstable phase, of course, you assess them every day. So then again, you come back the next day, you assess them again, and you're like, okay, it could be, I think those interventions are working, but they're still having really high distress scores. So we're going to keep them in unstable phase. Then you come back the next day, assess them again. You might find, for instance, that those symptoms that cause the unstable phase prior to that have resolved, but there's been another thing that's popped up. Another symptom or problem has popped up, completely different. You're like, okay, well, we still need to keep them in the unstable phase because I need to go away now and straight away do something to the care plan, make changes to meet this need. And then you come back the next day because you're still on assessing them every day while they're in the unstable phase, and you assess them, and all the interventions that you've been putting in place over the last 3 days are working. All the distress scores are coming down. There is nothing that needs to be attended to straight away. Everything's working. The symptoms and problems are all great. The care plan is meeting all of the resident and family needs. And you're like, okay, it would be appropriate to put stable. So you put stable phase, they're in stable phase, so then you come back, then you assess them the following week. Because while they're in stable phase, you assess them once a week. Still stable, no problems at all. And then you come back the next week, still stable, no problems at all. And then you might get for instance, a care worker might come to you and say, I've done the daily SAS. There's a couple of, moderate to severe scores in there. You go and assess a resident. You go, okay, actually, it looks like this resident is actively dying. I'm going to put them in terminal phase. And then once again, they're in terminal phase. So you're assessing them daily, of course, because if a resident is unstable or in terminal phase, you would need to be assessing them every day. So you come back and then you assess them again the next day, they're terminal, and the next day they're terminal.
mm,
I mean, if they may not all look like that, this is just an example. I mean,
yeah.
there is no right or wrong way to allocate phase. It's as far as the trajectory of it, it's entirely based on your assessment of the resident at that time and what needs to
Mm,
be done and how urgently it needs to be done.
yeah. And it's very true, and we know as well, things can change really rapidly or they can change really slowly. Every resident journey will be slightly different. The other thing that we get asked a little bit to do with phase, as you know, part of PACOP is this earlier identification of needs. And so sometimes what we might see with residents is residents entering into the outcomes collection for more palliative care symptom management, as opposed to just needing palliative care for end of life care. So sometimes you may see in your outcomes with the residents as well, they may be entered into outcomes, have some clinical assessments and some interventions for symptom management, and then you might have a period of a lot of stable phases. Did you want to talk about how that might look for care planning that and how we can then exit people from outcomes if it's not a terminal event?
Yeah, sure. So the outcomes is really designed to assess residents that we have identified palliative needs. So we could be going along with our profile assessments. We could identify a resident has palliative needs. So we commence them in the outcomes collection. Because they have some high distress scores or problem severity scores, or there is something that has caused us to put them into the outcomes collection. We keep them in the outcomes collection. We go along and we provide our care and we regularly assess them. And then the resident seems to stabilize. So we're not talking about being stable for a couple of days, or we're talking about being stable for a matter of weeks with really not much change. And then if that was the case, it would be advisable to look at this resident and go, well, do we still think this resident is likely to die within the next 3 months? Based on our assessing that we're doing, based on our clinical knowledge of that resident, do we still think this resident is likely to die within the next 3 months? And if the answer is no, it's absolutely fine to take them out of outcomes and put them back onto profile collection.
Mm-hmm.
It's not an exact science. So, as we all know, dying but the outcomes collection is sort of targeted at the last 3 months of life. And like Laura said, sometimes people stabilize and really we find that we're doing assessment after assessment on the outcomes collection, we're not needing to change anything at all. They've seemed to have rallied, so take them out of the outcomes collection.
And so we kind of touched on this briefly before when we were talking about the phases there on how to complete them and how that looks when we go and follow them back up. So the allocated phase determines how often we go back and reassess the resident. And as Nat was saying, the SAS is done daily under that assess, respond, plan clinical protocol. But when they're unstable or terminal, we're going to do that full assessment daily. And that's because, like Nat said, we want that high quality care, all eyes on that resident, prioritising care, monitoring for changes and communicating with families and with the team as well. And so when they're stable or deteriorating, that full assessment is done once a week.
And the assessment frequency based on the phase also helps you with triaging your time for your resident care. So if you were coming in to start your shift, you're handed over from the previous nurse. Okay, as you know, we have, this resident, this resident, this resident in the outcomes collection, and this resident is currently in a terminal phase, and this resident is an unstable phase because of these symptoms. They would then sort of triage your and prioritize the resident care for those people. So the phase works really well with helping you to focus your attention on those with urgent needs straight away, and then you can get to the stable and the deteriorating phase ones after those, if that makes sense. Yeah.
And especially in communication with the team as well, Nat. Often when we're talking about the phase and this daily SAS monitoring, some of the questions I get from staff are around, well, how much time does that take? And the SAS is really about doing that conversation in routine care. So really this phase and that responding, it really improves communication among your team where there's residents who are in these different phases, because if someone is unstable or terminal, you're going to do your routine cares, have that conversation about your SAS and then report those scores back to that RN or that supervisor quite quickly, because that they're going to be interested in what's happening with that resident for that shift.
Yeah, exactly right. Yeah. So phase is a really useful tool because, you've done your assessments, and then that is you're going, okay, what do I need to do and how quickly do I need to do it? Okay, this is the appropriate phase. It really helps embed that systematic reassessment based on need. Yeah.
So we thought we'd highlight some of the resources that we have on phase and to support you around your learning around how to use this really valuable tool. So part of the resources, they're all on the PACOP online resource portal on the PACOP shop for homes that are participating in PACOP. And there's clinical guides, there's that assess, respond, plan clinical protocol as well. We've got one-page tip sheets. If you want something quick, just while you're at the nurse's station, if you think, I just want to remember, what was it about that unstable component in phase? There's lanyard cards, there's SAS rulers, improvement facilitators like Nat and myself who work with your aged care homes and with your staffing teams. And then we regularly hold workshops all around the country.
And we'd love to hear from you.
We would. And there's also little videos and things on YouTube. So there's a wide range of resources that will work for your team. And at this point, I guess it's 10:23. Nat, I wanted to ask, what are the common questions that you get asked around phase?
I think sometimes people can be a little bit confused about phase. And I think as long as you remember that the phase does not relate to the phase of illness, but it relates to the care plan. So that the PACOP palliative care phase relates to the plan of care or the care plan for the resident and what you need to do. So as long as if you find that you're thinking, which phase is being a bit confused, just ask yourself the simple question: am I thinking here about the phase in relation to what I need to do for the resident, or am I thinking about it in relation to phase of illness? And as long as you bring it back to the care plan, which is the definition of our phase, I think it's actually a very simple and effective tool.
Yeah, absolutely. And talking about it with the team.
Yeah. That's right. Just reinforcing it. Sometimes, and it can be confusing because, doctors will refer refer to phase of illness quite often. It's just part of their lingo, and it has always been that way, and that's absolutely fine. But for the purposes of this program and PACOP palliative care phase, it relates to the plan of care for the resident. So next month, September morning tea talk, Laura. It is on frailty.
Yes, I was going to say, we are going to talk about frailty. So some of the feedbacks that I'm getting from aged care homes and even from inpatient services that are transferring residents into aged care homes, they're very interested in this idea of advanced frailty, and especially with our residents with dementia as well. You know, these residents that may not have you know, an illness that we would immediately think, oh yeah, that's a palliative care diagnosis. About frailty, why do we assess it? Why is it important? How does that look with things like ANAC Class 1 with the profile? So we're going to be having a really big chat about frailty.
And we'll give you you know, a slight little hint. You know, measuring frailty in this cohort is an excellent prognostication tool.
Yeah.
So very important.
I can't wait for that one. All right,
okay,
everybody, have a lovely day.
Thanks for watching. Enjoy the last day of winter. Yay
Okay.
for spring. And we'll see you and we'll see you next month.